All right, everyone, it's noon, so let's get started. Thank you all for joining us today for our Spring into Health event. My name is Haven Spanier, and I'm the Senior Director of Programming at the University of South Carolina's Alumni Association, and it's my pleasure to get to introduce our host to you all today. Just a couple of reminders before we get started. So if you aren't super familiar with Zoom, I just want to draw your attention to the panel at the bottom of your screen. There's a chat button in that panel. So if you want to go ahead and click that and have it pulled up, Dr. Williams wants the event to be very interactive today. So we want all of your questions in there throughout the event. We'll get to as many of those as we possibly can. I also want to give a big thank you to Prisma Health for making today's event possible. But without further ado, let's get started. Dr. Eric Williams has been the Assistant Dean for Student Affairs at the University of South Carolina School of Medicine, Columbia since February of 2018. Prior to that, he was a staff psychiatrist at the Student Health Center of the University of South Carolina, Columbia, and the psychiatrist for an ACT team in Charlotte, North Carolina for 7 years, while also serving as director of the Introduction to Clinical Medicine course for the first-year medical students for 5 years. Interspersed during that time, he did work in the juvenile justice system for 5 years. And in addition, he currently works with the Prisma Health ACT team. He earned an undergraduate degree in psychology from Wake Forest University and his medical degree from the Wake Forest University School of Medicine. He completed his general residency and child and adolescent fellowship with the Palmetto Health Alliance and the University of South Carolina School of Medicine. Dr. Williams enjoys teaching undergraduates, medical students, and residents. He currently co-teaches a junior-senior pre-med undergraduate class entitled Transitioning to Medical School. He gives dictates to psychiatry residents and child fellows and co-leads small groups for the medical students. His after-hours job pre-COVID was a body attack and body step instructor at Move Fitness, which he will resume once the mask ordinance ends. So thank you so much, Dr. Williams, for joining us today. I know we're all excited for this presentation and conversation.
Well, thank you, Haven. And I'm going to say thank you to Andy, Anne Marie, Ashley, Ellen, Haley, Paul, Robin. Please don't hurt me if I say this wrong. Sarag, Trekka, and Vincent, for all of y'all for joining on today. So as Haven said, I want this to be really interactive, and I want this to be a session where you can ask whatever you want, because a lot of people have not had an opportunity to interact with a psychiatrist, and they just have a lot of questions. So I'm going to start off with just a very brief PowerPoint. This is just 10 slides, and I'm not going to talk much about me. I want this to be for you. So I'm going to do a screen share. And first, talk about what a psychiatrist is and isn't. So my first slide, put that on. So hopefully everybody can see my screen.
Looks good.
Okay, thanks. So this part is about what a psychiatrist, again, is and isn't. Hollywood has an idea of what we do, and I'm going to play this to show you what we don't do.
Doc? Don't say a word. Doc, I don't want to know your name. I don't want to know anything about you.
Listen, Doc.
Quiet.
Doc.
Don't
Doc,
tell me anything.
Doc,
Quiet. Quiet. I'm going to read your thoughts. Let's see now. You come here from a great distance?
Yeah, exactly.
Don't tell me. You want me to buy a subscription to the Saturday Evening Post?
No.
Not a word, not a word, not a word now. Quiet. Donations. You want me to make a donation to the Coast Guard Youth Auxiliary?
Doc.
Okay, so that's an idea of what people think we do. Not quite accurate. This is more what we do. Normal people, we're one human. This is what I tell my medical students: one human talking to another human who is going through some problems. That's it. So this is it, not this. Group therapy we do, yes, no, yes, no, well, maybe. So this is also what Hollywood thinks we do. It's we tell people to lie down on the couch and we sit with this pad and say, okay, tell me about your mother. Now that does exist, and there's a type of that's a type of therapy called psychodynamic psychotherapy. But day to day, that's not what most of us do. And yes, I'm a child psychiatrist, so I work with kids, adolescents, and adults. So here's one of the biggest questions I always get. What's the difference between a psychiatrist and a psychologist? And I love this picture because it really shows what some of the similarities are. We both work with mental health and we can both do therapy. So I wanted to get that out in the front because sometimes people think psychiatrists, they do meds and psychologists do talk therapy. One of the biggest differences is in the type of education. One's not better or worse, they're just different. So as a psychiatrist, I've gone to medical school, so I have an MD degree. Psychologists don't go to medical school, but they can have PhDs, they can have masters, but the medical school is the difference. So as a medical doctor, I've gone through rotations such as surgery and internal medicine and done biochemistry, physiology, all of those. So we know about physical and psychological aspects of problems. And we can do, yes, as medical doctors, we can do medications where, at least in this state, psychologists do not. Okay, I told you my PowerPoint was going to be very brief. And so I hope everybody was able to see that. So just I'll give you a little bit on what I do now, day to day when it comes to psychiatry. So one day a week, I spend on the Prisma Health, what's called an ACT team, and that's assertive community treatment. And that's a national model in which we work as a large team. So our team is currently our team lead, who is a social worker. We also have a vocational specialist. We have a housing specialist. We have a peer support person. We have an outreach person. We have a nurse. And these are all folks, we work together to wrap around services with about 50 people that we see. And those 50 people have severe, persistent mental illness, usually schizophrenia, bipolar, something like that. And to be on our team, you have to at least start it out as homeless or at imminent risk of being homeless, which is why we have a housing specialist. But our job is to keep people out of the hospital. So who are we seeing? We're seeing the person who, if you're downtown, you might see someone just walking down, maybe homeless, and they're talking to themselves. That would be a person who could be on our team. And homelessness and other socioeconomic factors require a whole lot of wraparound services, so that's what we provide. I also see other people in the office at Prisma/USC at 15 Med Park at the hospital, and that could be anything from depression, anxiety. I used to have an autism clinic with the Department of Mental Health. I still can see schizophrenia, eating disorders, anything that falls into the mental health realm. We see there and we can diagnose and treat. We also work with a team, not just on the ACT team, but at 15 Med Park, we have psychologists there. We have our nurses there. A lot of people that work with us to do our best to help the people that we see. So I'm going to do a quick transition, and then really, I promise, I'm going to open it up for questions. And you can ask. We've got some new people that joined us. There is no such thing as a question too big. There's no question too small. There's no dumb or silly question at all. Ask whatever you like. So what I often get asked to talk about during this time is mental health and the pandemic. which hopefully soon will be coming to somewhat of an end and we can get somewhat back to normal. But what I've heard a lot from people is how do I deal, or how, well, we'll say present tense. How do I deal with the isolation? How do I deal with the stress? How do I deal with not knowing if I'm safe going out of the house? What if I've already had a pre-existing mental health condition? What if I've already been depressed? I'm already anxious, and this is making me more depressed and anxious. What do I do? And if I don't know what to do, who do I see? How do I even start to get help for that? And happy to answer all of those. If you're having problems with anxiety, depression, or know people who are, and they just don't know where to get help, you can always start. If you're working, your EAP should be able to tell you who's available for you to see. If you're a student, student health or someone like me that works with student affairs can help you. Or if you're complete I was gonna say civilian, and maybe you work for yourself, you can always start with your primary care doctor, and your primary care doctor can get you to the therapist or psychiatrist or whoever it is you need. And if you have no primary care doctor, shoot me a chat or something like that. I don't know if as panelists y'all are able to directly send me a chat, but happy to get you whatever help you need. So in this time, some of the things I've heard from people are some feelings, again, of isolation. Of what I've really heard a lot of, sort of surprisingly, not surprisingly, are feelings of guilt with people who might have passed due to COVID and they haven't been able to attend their funeral. I did a church presentation and I got a lot of that. I should have been there. I couldn't be there. I let the person down. And they're feeling like they did something wrong in an environment where they had no choice, because we just couldn't see people, couldn't hold our usual services or funerals, that sort of thing. Day to day, I do therapy, and not as much as I'd like to, but do some therapy and do medications. And people often have questions about medications, and I'm happy to answer any and all questions that you might have about that. Do people always need medications to get better? No, they don't. Do people sometimes need medications? Sometimes it can be extremely helpful, but it depends on a case by case basis and what the person is comfortable with. As I promised, because I want to be here for you all, and I've never had a session where we just didn't have questions on questions on questions. And I want to give you that time to ask anything you want. I'm gonna back off and be kind of quiet, and I really want you to ask anything you want, anything whatsoever. That's what people usually tells me is the most helpful for these. You don't want to hear me just talk about me. You want to be able to ask stuff. So if you want to go straight to the chat and put in, all right, already got one. So what made you interested in this field? I've always liked talking to people. I think talking to people is interesting, fun. As a undergrad, I majored in psychology, and I thought my classes in psych were just the most fun things in the world, because you get to learn about how people work and what motivates them and what they do, how they think. It was so enjoyable. And so the natural progression for me, because I did know that I wanted to be a doctor, was to go into psychiatry. And so I would say we're probably one of the fields in medicine that gets to spend the most time talking to the people that we see. For example, for a new patient visit, I get an hour. I talk to people for a long time, because we have to find out not just what's wrong, but who are you? What are the other parts of you that make up who you are and might be playing into what's going on? The depression often, I'm just going to give an example. Depression often isn't just a chemical imbalance. There have been times, there might have been some stressful situations that are going on that lead to that, or there might be, maybe you're on some other, have some other health problem, And one of the things that can manifest as is a psychiatric problem. So just that interplay of working with people and mental health, that's why I went into the field. Okay, we have a lot. All right, so I'm gonna start going through these. I'm gonna try to do them based on timestamp because we have Q&As and chats. So, do you think Prisma is better than more individual hospitals? Honestly, I'm probably not best to answer the question because when I moved here to Columbia in 2000, that was when it was before Prisma. It was Palmetto Health, Richland. Then that's the system I worked in, and then I moved to North Carolina for 1 year and didn't work in a hospital system, and then came back, and I was back with the Palmetto Health system. So I really don't know other hospital systems. So I'd love to be able to answer the question. I'm just not able to give you a good answer on that because I don't know other systems. It seems that so many adolescents and high schoolers are diagnosed with anxiety issues. How can we as parents help them? Why do you think so many children have this issue now? I don't feel as though my generation experienced this as much. We could talk about this for the whole hour. Okay, so yes, and I could about adolescents and high schoolers diagnosed with anxiety. That I can speak firsthand on, having worked for 8 years at the University of South Carolina Student Health, so on the main campus here. And every year, the number of students we saw went up. And I would do some research. I did some research looking across the country, and everybody is saying the same thing. We're seeing more students with especially depression and anxiety, but anxiety was by far the number one thing we saw at the Student Health Center. More students with anxiety every year, and more severe anxiety. So there were a couple of reasons why we thought that might be happening. As far as college goes, we're thinking we were seeing more students with anxiety and other mental health issues because of the treatment that they can now get. Let me tell you what I mean by that. So let's say 30 years ago, you had anxiety that was really bad. Maybe you didn't get treated, and therefore you couldn't make it to college, or you couldn't make it through it. Now we have students that can be treated, so yes, they can make it to college, and we continue to treat them there, so they can be in college with some anxiety issues. Another reason, this is more so depression, and this is one of the things that we know now after almost a generation on social media and phones. One of the leading reasons, teens and problems with depression and anxiety. This. There's a lot more time being spent on this than being out with other people and learning how to navigate stressful situations, or how do you navigate disagreements person to person. We got some pretty solid evidence that the more time teenagers spend on this, the more likely we are to have some depressive diagnosis. That doesn't mean that every person who has a phone is depressed. That just means there's a decent correlation with the amount of time on the phone and social media and feelings of depression. So when you say at the end, I don't feel as though my generation experienced this as much. One of the big things, again, we didn't have this. The question now is, how do we navigate through that? If I had the perfect answer to that, I probably wouldn't be sitting here. I'd be making policy somewhere. I encourage people to get out as much as possible and get off the phone and get on a face-to-face. And this is the last thing I'll say about that because we have several other questions. But that's one of the things that's made the pandemic especially difficult for our kids and adolescents, is they haven't been getting that face-to-face time. School's been closed. Being virtual isn't the same as face-to-face, so it's made it a lot tougher on them. So it'll be great when they can get back safely, still stay safe, and get back to some of this face-to-face interaction. All right, so the next one was 1215. What is the status of ketamine, psychedelics, and other alternative treatments in the U.S.? Hot topic right now. So to talk about what some of these are. So ketamine, if you are of a certain younger age, you've probably know it as a club drug or Special K. If you're a certain older age or in the medical field, you know it as an anesthetic. It's both of those things and other things. If you're in the field of mental health or psychiatry, you might now know it as an antidepressant. So ketamine does have some indications, and they're FDA approved for depression. There's nasal and there's IV. Psychedelics, again, for those of you that of a certain age, if I have any therapists on here who are doing therapy in the 60s, 70s, they used to use psychedelics in therapy, specifically ecstasy, because it helped open people up and made them more willing to talk, and they felt like they could make more progress in therapy, and then it got turned into a Schedule 1, nobody can use this drug. And now we're looking at, are there safe ways and are there good indications to use psychedelics within therapy or mental health treatment? That's jury's out, studies are being done. Ketamine, yes. Other psychedelics, still being studied, but it's being open to study. Okay, 1216. I'm a certified peer support specialist, certified in New Jersey. Can I apply my class that I've taken through Mental Health Association of New Jersey to a master's degree in psychology, or classes to a master's degree in psychology? I would say, to get the best answer to that, I would take that to whatever school that you want to go into, that you want to get your master's degree from. And I'm basing that on thinking about USC and Midlands and our schools around here. Different schools will take different credits that you've done already. So you want to make sure that this school will take whatever credits that you did for your peer support specialist certification. So ask that question. Okay, I recently moved to South Carolina at the beginning of my undergrad years, and I'm interested in practicing psychiatry. I am concerned about being able to provide culturally competent care, given that I am not from this state and would like to see primarily South Carolina born individuals. I'm telling you, you're already ahead of the curve that you even recognizing this. I have made a great effort to volunteer and work in many spaces to engage with the South Carolina culture I have come to know and love. But do you have any experience or advice on how to navigate working with those different from yourself? I want to copy this question, paste it, and give it to my students. I love this so much. And yes, I do. So I'm going to tell you what I tell our students. The way to learn, one of the best ways to learn about other cultures is to ask and not be afraid of looking like you don't know anything. So let me give you some examples. So here in South Carolina, didn't say exactly where you came from, but I'm going to assume I'm just going to make an assumption. I'm going to assume it's not the South. And even if that's true, let's just go with that. So just the South as a region is a culture. South Carolina in itself is a culture. The low country part of South Carolina is a culture. And there is no way for any one person to know everything about every culture. That's just impossible. So how do you learn it? You ask. For example, let's take low country. And I give this example a lot. So well, I'll have someone who, that's from the Charleston area, Beaufort area, and let's say, unfortunately, they just had a family member pass away. And they come to me and they say, you know, I'm really sad, this family member's passed, and that's understandable. And they say, but I've been hearing, well, let's say grandma. I've been hearing grandma coming, talking to me during the night, and we'll have conversations. And then she says goodbye and she goes, and I get on with my day. Okay, so if I didn't know much about the culture down there, I might think, okay, this person is hallucinating. They might have schizophrenia or something like that. But knowing that, and this is a possibility in that culture, that it's totally normal. It's expected that your loved ones will talk to you, and so it's not a mental illness. It's just the culture. But if I didn't know that, how would I ask? It could be something as simple as, so that's really interesting. Has that happened before, or tell me about that? And it maybe just with being open and being willing to listen to the person, and they see that you're willing to listen, they'll start to tell you, well, that's like, my mom did that when my mom's doing that because grandma died, and my aunt did that, my uncle did that. Being open and showing that you're willing to listen will often open up the other person to kind of invite you into their world, into their culture. And if you don't know something, the other thing is to say, I don't know. Teach me about this. Tell me about this. You can also take advantage of seminars or lectures or experiences about the South Carolina culture. Just 3 months ago, with the medical school, we had a gala Zoom event where we had a screening of a gala movie and some people who went over to Africa. It was these kind of events and opportunities are there. Um, just look for those and be willing to go to them and learn. But the biggest thing, navigate working with those different from yourself, be open, show that you're open, ask questions. People appreciate being asked, and not when people assume that they know something about them. So I really love that question, and thank you for it. Do you have suggestions for dealing with a very negative person, and in parentheses, a relative? I can't, Ellen, give you a blanket. That'd be one of those where I would really need to know more about what's going on. But I can say the fact that you asked the question kind of leads to, well, you haven't just written this person off and you want to know what to do about it, or what to do about them. I would need a little more information. And so, and I have no problem doing this. I do this whenever I give a talk. I'm going to put in attendees. I'm going to give you my office number. And you are free to call me and we can talk a little further. Yeah, I'm gonna stick with it's really going to depend on what's going on. I don't want to make a blanket statement, but I am happy to help in any way I can. So please give me a call. Just trying to think of if there's anything. Do you have suggestions for dealing with a very negative person? Yeah, give me a call. Or if you want to put a little more info in here, I'm happy to answer as best as I can. So Robin asked, is there a shortage of psychiatrists? Yes. How does this compare with other medical disciplines? So there's a map of the United States, and in which the American Academy of Child and Adolescent Psychiatry sets up from state to state. It's got these colors on it, and it shows, is this state severely, is there a severe shortage? Is there no shortage at all? Are there enough? Are there too many? As far as child psychiatrists go, there's one place in the country that has enough, and that's Washington, D.C. I don't know why, but they do. Every place else has a shortage. Even in Columbia, I don't know where most people are, but even in Columbia, where we have a medical school, a teaching hospital, there is a shortage everywhere. How does it compare with other medical disciplines? I am trying to think if we just have too many of a specialty, and I can't offhand think of one. What we need, I could say we need more of just about everybody, especially those that are able to take care of our aging population, our baby boomers. There are a whole lot of them, and we need people who are more trained in geriatrics, whether that's geriatric psychiatry, geriatric medicine. We definitely need a lot more there, and we need a lot more in our rural areas. South Carolina, we have 3.5-ish urban areas, big city areas: Charleston, Greenville / Spartanburg, and Columbia, and maybe Augusta / North Augusta, but half that's in Georgia. So yes, definite shortage. So if you're interested in medical school, we can use you. All right, Andy writes, what are your favorite and least what are your favorite and least favorite parts about being a psychiatrist? Favorite, talking to people, hands down. The interaction that you get to have and with just so many different people is it's a gift. It's a gift that people give you when you get to be their psychiatrist or just their physician, period, because the people that you see, your patients, they reveal things to you and they trust you with information that they give to nobody else. There are things that people have trusted me with that they're not going to tell their spouse, their parents, their friends, nobody. They come to you for help and you're able to help. That's the best part about being a psychiatrist. And I'll probably say about being any physician or anyone in a helping profession. You're able to help. But honestly, I'm going to go so far as to say anybody in many professions, period. If I'm an air conditioner person and in 1 month when it's going to be 100 degrees 2 weeks straight and my AC goes out, I'm sure the air conditioner person is happy to be able to help. But that's what I love about being a psychiatrist. My least favorite part about it is probably the least favorite part you'd hear from just about any physician or nowadays, paperwork. Yeah, that's just not fun. Yeah, I got nothing else to say about that one. It's paperwork. Do you think that the stigma of being diagnosed with a mental illness is lessening? This is a question coming from Robin. If so, what do you attribute that to? Robin, I'm glad you asked that question. And I might be a little biased. I'm going to say yes, and here's why I'm going to say that. I do come from the student health college background, and I think it's certainly lessening with our young adults and teenagers and kids. Here's something when I was over there that surprised me a lot. So I'll get them from the waiting room, and we're walking down to my office, and because I know where my office is, I'm usually leaving, and so I'll come in, and they'll come in, and I'll sit down, and they'll leave the door open, and I just kind of get like, and part of me is curious as to, are they really gonna let me start a psychiatric visit with the door open? And I'm just looking to see if they're gonna get up and close it, and they don't. I mean, okay, eventually my anxiety gets in the way, and I say, okay, can you get the door? I'll get the door. But just the fact that they're okay with leaving the door open says to me that the stigma of that is lessening. I'm going to give you another example of that. So I used to take students on medical service learning trips when I was at USC, and we'd go for spring break to some country or something like that. And one of the times, one of the students I saw, it was one of my patients with psychiatry with student health. She went on the trip with me, and she told everybody, Dr. Williams is my psychiatrist. I see him. And I couldn't imagine 20 years ago somebody doing that. Like, she wanted people to know that she got therapy and she was seeing a psychiatrist. What do I attribute that to? I attribute that a good bit of that to it's now becoming normal to know what a psychiatrist is, to talk about mental health. I mean, think about the national conversation that we've been having about mental health lately. This is not just, okay, we're just going to talk about mental health to this little group of people over here, and shh. This is a big thing. And we talk about mental health in schools. We talk about mental health. Like I said, I go to my church, and we'll have conversations there. So I think we're normalizing mental health more. And the more we normalize it, and the more that people realize, oh, it's not just me, because it's never just one person. It's not just me, then that could take away the stigma too. If it's, you know what, Aunt Sue also has depression. You know what, Uncle Joe has been worried about anxiety too. I'm encouraged by the fact that psychiatry is now being integrated into primary care practices so that patients can be treated on site. Your thoughts? Exactly what we've just been talking about. So if I go to my primary care physician, like my internal medicine physician or my family physician, and the psychiatrist is there too, that says to me, this is a part of health. This isn't some carve out of health. That like there's your physical health and then there's your mental. No, this says to me, this is health. All of this goes together. So I love that. And being in the primary care offices and being integrated with them is one of the best ways that we can get, that we can provide access to people that might not otherwise have had access to mental health services. So yeah, I think that's one of the best things that we've done. From Anne Marie, is substance abuse addiction something covered by a psychiatrist? Yes, that's pretty much our wheelhouse. So if someone has, yeah, I'll just do that is part of what we do. And in fact, that's so much so what we do that there's a specialty called addiction psychiatry. And if someone after doing their regular residency wants to specialize in addictions and substance abuse, they can do another year and just do that. That reminds me, so let me back up a little so that I don't seem, I want to give out a little more information. So how does one become a psychiatrist? So we do, of course, the 4 year or however many years of undergrad. You have to get your undergrad degree. That's not totally true. So here at USC, we have a program where students can actually be accepted into medical school their first or second year. And so they do 3 years of 3 years of undergrad and go right into medical school their 4th year. But that's few and far between. So most people, you get your undergrad degree. Then you do your 4 years of medical school. And traditionally, the first 2 years are what we call classroom or basic science years. That's physiology, biochemistry, anatomy, pathology, pharmacology, immunology. Pretty much in the classroom, learning those, learning the facts, learning the mechanisms, what's normal, what's abnormal. And then your second 2 years are what are called the clinical years. And that's when you've left the classroom, you go to the hospital or you go to the outpatient clinic, and your day-to-day is working in the clinical setting. You actually see patients and you round with the medical team. You still take tests and you still read and you still learn, but you're doing, students will say, this is what I came here to medical school to do, to actually see patients. Everybody for the first 3 years does the same thing. 4th year is where things get a little different. And that's going to depend on what you want to do. So with me going into psychiatry, I did more psychiatry rotations my 4th year. Someone going into surgery is going to do more surgery rotations their 4th year. And then you apply to residency. Everybody does that well, also not true. Most people do that at the same time across the country. And then everybody finds out pretty much at the same time where they're going. And then you graduate medical school and you go into that residency. So for psychiatry, it's there's a lot of caveats in everything. As I say, everybody does 4 years, also not necessarily true. Most people do 4 years of general psychiatry. That means adults, pretty much 18 to 65. Everybody has to learn that. If you want to go into child, you can cut off 1 year of adult and do 2 years of child. So I did a total of 5 years. I did 3 years of adult, 2 years of child. So that then put me from 0 to 65. You can do geriatrics, 65 and up. Does that mean I can't see 67 or 72-year-olds? I can, but I'm not specialized in it. I could have done a consult liaison fellowship, meaning that I work in a hospital on a consult service. So if the primary care person, the primary care person in the hospital says, hey, we need a consult on Mr. Smith, then I would go and see Mr. Smith and report back to their primary team. As we talked about, we have addiction psychologists. We have forensic psychologists. Did I say psychologist? Wow, psychiatrist. So psychiatrist, where you see a lot of that on TV. They're recreating what was in the mind of so-and-so when they did this crime. Forensic psychiatrists often go to court and evaluate people. So there are a whole bunch lots of different options. Okay, got another one. What's your favorite medical related book? Hmm. Mm-hmm. I'm going to say, let's see, well, I'm not so sure if I can answer this question live. Okay, I wasn't quite sure what that one meant. But one of my favorite books is uh, anything by a surgeon named Atul Gawande. I use that book in teaching a lot. Actually, I can show you. No, I can't. But there's one called, the last name is Gawande, Gawande, and the first name is Atul, Atul. And I use that in my classes. So Dr. Gawande is a surgeon who writes about what it means to be a doctor and what it means to practice medicine. And what I really love about his is the stories. So every chapter has a story about a patient he's seen or some type of situation that's going on. And he talks about how what does it mean to be able to be a doctor and to be able to, in some of these chapters, help people. In some of these chapters, what does it mean when your doctors might slip and fall? How do we deal with that? How do we make sure that the people that are practicing in the profession are safe? What does it mean, and why do we wash our hands so much? Why is that so important? So I love those books because of, one, the stories, and people relate to stories, and just the breadth of different things that he captures, and because it's easy to read, it's easy to understand. It's not a book full of medical jargon. You come away from those books feeling that you learned something, and you can understand what he's talking about. So I highly recommend those. Those are just good books to read, period. Robin says, what would you say that your undergraduate degree needs to be in psychology, or do you see other majors being accepted in higher numbers? Far and away other majors. It does. So one of the things I've done in the last 3 years is I've been on the admissions committee here at our med school. And so I get to know the majors of what majors people bring to the table. I'd say probably the biggest ones are biology, biochemistry, and exercise science. Exercise science the last several years has been growing, but does it matter? It absolutely does not matter what you major in. We've had engineering majors, dance majors, Japanese, visual arts, English, for psychology, chemistry. It doesn't matter at all. As long as you do the prerequisites for taking the medical college admissions test, that MCAT test, and you've taken the science courses you needed, we don't care what your major is. Actually, we love having diverse majors because that makes for diverse doctors. It makes for a diverse class. So yeah, whatever you want to do in undergrad, do it. How can you help support a loved one struggling with their mental health? One, let them know they're not alone. That's one of the biggest things when I see anybody. One of people's greatest fears is, I'm the only one dealing with X. I've literally had people come in and say, I'm sure no one else is depressed, when that's one of the most common things we see. I'm sure no one else is anxious. That's the most common thing we see. So breaking through some of that stigma that was mentioned earlier is to Robin mentioned earlier, let them know that it's just not you going through this. You're a human just like the rest of us. We all go through things. Okay? And then get them help. So I'll go back again to, how do you get them help? If they have a primary care physician, great place to start. That primary care physician often can treat, let's say if it's depression or anxiety, they can often treat that themselves. And actually, primary care physicians write more antidepressant prescriptions than we do as psychiatrists, because they're kind of the gatekeepers. And people will go to their regular doctor that they've known first before coming to a psychiatrist. So find them help. If the struggle is a struggle of imminent danger, so we're talking to the point of, I think this person might be suicidal, or they might be trying to go after somebody else. If we're talking imminent danger, then that's 911. Let's get the ambulance here for their own safety and safety of others. We need to get them evaluated right away. At 911, of course, is available 24/7. So imminent, 911. How do you treat people with delusions and paranoia? So that's a lot of what I do on my ad team. So delusions and paranoia, a lot of that is, well, not a lot of that. Sometimes that's caused by schizophrenia. And schizophrenia, we use medications. There are therapies that can help with some of the things that come about because of schizophrenia, but there's not a therapy that is going to let me go back up a little bit. We know a fair amount about how schizophrenia works as far as different brain pathways and brain chemicals. So we don't have a therapy that's going to attack those brain pathways and chemicals, but we do have therapy that can help with, because I have schizophrenia, I might have problems with socializing or something like that, but delusions, paranoia, often will be medications along with other wraparound services. Have you ever lost a patient to suicide? Straight suicide, I will have to say not yet. And the reason I say not yet is because we're taught in residency that unfortunately with suicide, it's not a matter of if, it's a matter of when. So I've been out of residency now for 16 years. I haven't had that a direct suicide yet. I have had someone who, actually that wasn't suicide at all. This was a person who didn't kind of know what they were doing and they jumped out of a moving car, but it was not a suicide attempt. So no, I have not yet lost a patient to suicide, but I know many who have. And that's always a very harrowing experience for the patient and for the patient's family and for those that treat them. Okay, 12:48. We're getting close to time. Haven, do we have to stop at 12:50 or do we go to 1?
You can go to 1.
Okay, so we do have time for more questions. How are you able to turn off your work when you go home? What about work-life balance? Robin, this is another question I'm going to copy and send to everybody. You hit on probably I'd say that's probably the hottest topic or the most relevant topic in healthcare right now is work-life balance, burnout. Everybody's talking about that, from people who have been in the healthcare field for decades to we're talking about it with our medical students. We're even talking about it with our pre-med students. Huge. So how am I personally able to turn off my work when I go home? Not the best at it, I will admit. So I only see patients 1 day a week. The rest of my time is the assistant dean of student affairs here. And I'll say I probably have more problems with turning off the student affairs part than I do with the patient part. I don't know why or how, but I've usually been able to go home for my patient part. Work-life balance, that is a skill. And I think with so many people talking about this, that must mean it's pretty universal, which means we don't know how to do it well if so many people are asking that. So that's something that we probably need to be taught. The good thing is we're talking about it now. And just like the stigma of mental illness, it's okay to say, or it's getting okay to say, I'm feeling burnt out. Whereas maybe many years ago, you wouldn't dare say that because, oh, you're just weak. You don't really care about your patients. It's not about you, right? How can you say that? You want to be a doctor. That's what you should give 100% all of the time, and that's not realistic. So work-life balance is huge on everybody's radar. You're not going to escape that. As a psychiatrist, would you be open to seeking help from a colleague? Absolutely. Would you want to seek out someone who specifically sees other physicians? Some do. So, help from a colleague. So I guess getting, oh, okay. Actually, I think I see how the question's being written now. I'm going to make an assumption about the question. As a psychiatrist, would you be open to seeking psychiatric help from a colleague? That might not be what is intended, but I'll answer both psychiatric and physical. Psychiatric help from a colleague, I'd probably say, ooh, man, you gave me a really, I would have to think about that one. Physical help from a colleague, like a colleague being a primary care physician, absolutely, no problem whatsoever. Oh, you're gonna make me think, I'm gonna earn my money today. I might come back to that one. Would you want to seek out someone who specifically sees other physicians? Anonymous attendant, you're killing me, but I love these questions. I will say I haven't done that for my primary care physician or any other person I see. So for me, not necessarily. But for some others, I see how they would. My guess is, whether they know it or not, people see other physicians. So like when I go to my primary care physician, I don't go in like, I'm a doctor. So you probably end up seeing someone who sees other physicians, but you said specifically. That's not necessarily for me. I'm still going to come back to that psychiatrist, so would you be open to seeking psychiatric help from a colleague? Tips for anyone dealing with stress, burnout from job or a busy lifestyle? Yes. And I know this is easier said than done, and this is very much an American thing. Use your vacation days. We are horrible in the US of A with not using our time, because we often feel like, one, we can't, not money-wise, but we can't afford to take time off, because that just piles up the other work and you have tons of work, even more work when you get back. I'm guilty of that, or I was guilty of that. I use every single day now. Also, when we do go on vacation, we work. Also guilty of that. We weren't meant to function at 100%, 100% of the time. You just can't do that. You want to burn yourself out? Try to do that. I remember taking my econ class in high school. We applied economics, so we had somebody come in and talk about, I don't know why this person was talking about machines, but he was saying, you run your factory at 80%. You don't run it at 100. It wasn't designed to run at 100 all the time. We weren't either. You have to unplug sometimes. Be that metaphorically from the job or from the busy life, or be that literally from your devices, your phone, whatever. Whatever you need to recharge, give yourself permission to do that. And I say give yourself permission is because we often will feel guilty for taking time off. And I think some of that's just built into us in our, American culture. Work, produce. And we weren't designed to do that. Another question, what is your favorite vacation spot, and what is your top thing to eat there? Oh, easy. Favorite vacation spot? Mexico. Going there next month. Next week. Leaving on Saturday, coming back the Saturday afterwards. Top thing to eat? Anything edible. That when we talk about dealing with stress, burnout, one of the things I do. I find eating new foods fun, relaxing, but exciting, enjoyable. And when I do that, I'm in the moment of, let me enjoy what's there. And that's another tip for dealing with stress, burnout. When you've unplugged, be in the moment. If you're on the beach, be on the beach. Not just physically, but also here. Turn this off for a little bit and enjoy the time you have. If you love spending time with family, spend the time with your family. Be mindful about what you're doing. So believe you me, when I'm at a food festival, I'm very mindful of what I'm eating because it's enjoyable. Yeah, I think we got 3 minutes left. So if anybody has, oh, I told anonymous attendee I'd come back. Okay, as a psychiatrist, would you be open to seeking psychiatric help from a colleague? If it were, oh, I'm gonna reflexively say probably not, and here's why. So, especially with psychiatry, and I could go into this for another 10 minutes, I only have 3. Especially with psychiatry, the power differential between physician and patient is really great because you know so much about the person that you're seeing, and they know little or next to nothing about you. And for some of it to work, sometimes especially with therapy, it's got to be that way. You have to know a lot about your patients, and they are not supposed to. They're not going to know nearly as much about you. So with a colleague I probably already talk back and forth with. We might go to lunch and stuff like that, and so the differential there would be so great. I think it might be hard to be just a colleague again. Whereas if someone were seeing, doing my yearly checkups, I'm okay with that. So then I would probably say no to seeking psychiatric help from a colleague for that reason. Thank you, anonymous attendee, for making me think. I appreciate that. We got 2 minutes left. Oh, Haven's back. Okay, I think I'm out of time.
I'm back, yes. All right, well, thank you so much, Dr. Williams. That was fantastic. Everyone had wonderful questions, so I appreciate everyone's engagement in the event as well. We have one more health event left in our series this spring next week. So if you all are interested in that one, you can visit uofscalumni.org/events. Lots of other great events coming up as well, too. I want to thank Prisma Health again for the partnership in this Spring into Health series. And a huge thank you again, Dr. Williams. That was just wonderful.
Certainly, and I just leave you with the number I put on there. I put it there for a reason. If you have questions or you need to get somebody help, give me a call. I am here to help.
Great. Well, thank you all so much. Have a wonderful afternoon.
Thank you. Thanks for the opportunity.